One of the defects of our fairly large clinical trial was our top dose. I'll just explain how this comes about, because I need to explain this before I explain the data. MTC is good old methylene blue, and it's been in clinical use for a long time. In fact, Paul Ehrlich made it a long time ago. It turns out that, and we only discovered this from the clinical trial, that what's critical for cognitive efficacy is that it be reduced and be absorbed in the reduced form. Here it's actually colorless, and here it's blue. That it be absorbed in this form. The net effect in our clinical trial was that the top dose failed. Let me just show you this. So the trial was 321 subjects. They were randomized to control 30, 60, and 100 milligrams 3 times a day in gelatin capsules. And when the controls had finished 24 weeks of placebo, they went into what we thought would be the top dose, the most effective dose. And I graded out to show that effectively it was a 0 dose. So this shows the comparison of placebo and 100 at 24 weeks. We've got nice efficacy at 30 milligrams, 60 milligrams, but the 100 has just failed. And if you look at these people, their ongoing decline after, I'm measuring here on ADAS-Cog, which is a standard cognitive score here. You can see that their continued decline is essentially identical to previous clinical trials. So the 100 milligram dose really, really did fail. So having said that, I'll just say the main results. So it was a fairly typical AD trial, as I say, 321 subjects, mostly here in the UK, one centre in Singapore, pretty standard entry criteria, age, I won't go into other details. The 24-week results I've already shown you. Milds did not decline at all over the first 24 weeks, but the moderates did decline, and as I showed you a moment ago, we got good efficacy at the 60 milligram dose, the 30 milligram dose, but the 100 didn't work. And this was significant after full correction for multiple comparisons. Interestingly, these show the placebo decline. So here are the moderate placebos who just decline, and here are the milds who don't, but when they go on longer on this ineffective dose, when they were switched, they just decline normally. Now, during this time, you would think, oh, well, they've been all right, nothing much has happened to them. But we did statistical parametric mapping analysis of their SPECT scans and showed that in the mild subjects, there is highly significant decline in neuronal function, even though their cognitive function is not showing. In other words, these people still retain the capacity to reroute the tasks that you're testing with ADAS-Cog, even though their brain is declining. In fact, there's 77% decline over 26 weeks. And in this group, although we couldn't show efficacy with the clinical outcome, we showed a beautiful efficacy on the scan. So the drug really did prevent the decline. A 50-week analysis. Now we're able just to pool everybody. By now the milds decline, and we have, again, a nice response here at 60 milligrams, and there are just different ways of doing the analysis. It's all highly significant. The issue in AD trials is how you correct for biased withdrawal. So we've just used different analyses. This is Z-score imputation, a nice effect in both milds and moderates. Here is slope-wise imputation. The effect sizes look a bit bigger. And it doesn't matter how you do the analysis. Last observation carried forward, Z-score imputation, linear imputation. The net effect is that there's an 84% reduction in decline over 50 weeks. We got the same result at 24 weeks with a global outcome measure, and coming back to this simple mini-mental scale, we got the same sort of effect. We've prevented decline. In fact, over 102 weeks, which is how long the trial ran. You can see this more clearly in the Z-score analysis. We've shown the data here out to 102 weeks. So for 2 years, we've pretty well stopped progression of Alzheimer's disease. The side effects, the main side effects were urinary. The stuff is mostly excreted in the urine, and diarrhea because of failure of absorption, particularly of the 100 milligram dose. Much better side effect profile otherwise than the standard cholinesterase inhibitors. And there was this is the normal range of met hemoglobin. There's a small tendency to oxidize hemoglobin. We've just recently done a frontotemporal dementia case, which was really exciting. This was a genetic mutation. The person had a C2T mutation here at position 16 in this loop. These are all the mutations, by the way, which cause neurodegenerative tauopathies of one kind or another. But we were lucky enough to catch one of them. 2 to 3 year history of personality change, 5 to 9-year-old, SPECT scan typical of frontotemporal dementia. The expected decline would be 13 ACER units, which is the Adam-Brooks Cognitive Examination revised scale. He started on MTC 60 mg 3 times a day in October of last year. And you can see that he started at an ACER at 62 and is now gone up by 13 units. So the effect size is 26 units. So this really has worked on a proven tau mutation case. So the bottom line of all of this is that it is possible to treat Alzheimer's disease, that we get scan effects precisely in the regions where the tau pathology is the most severe. And this shows the statistical parametric mapping of the SPECT scan. And if we come back to this, the real challenge, therefore, in terms of preventing Alzheimer's disease, is really to identify people at Braak stage 2 and to initiate therapy as soon as possible. There's a massive number of people who are Braak 2 or beyond in the world. There are, by 2050, there'll be 1 billion people who are of the age of 65, and of those, we calculate 600 million of them will be at Braak stage 2 or beyond. Thank you.